continue our discussion, the lectures of the clinical chemistry. So we have today is lecture 10. So the first I will talk about the creatine kinase. As you can see here, the creatine kinase increased in the damage of the skeletal and the heart muscles. So from its name, the creatine kinase enzyme, which is increases when there is a damage in the skeletal and also the heart muscle. So in the damage of the muscle, whatever is the origin, even is the skeletal or the heart muscle. So as you can see here, in the severe muscle destruction, CK in the serum, it will be more than 200 times the upper limit of the interference. So it will be an increase over 200 times. But the question is, what is the function of the creatine kinase? As you can see here, we have here the creatine, and by the help of the creatine kinase, and we know the creatine kinase, that's mean add the phosphatic group to the creatine, and it needs help from the ATP to change it to the ATP, so that is lead to the phosphocreatine. So the creatine, by the help of the enzyme creatine kinase, that is used the phosphatic group from the ATP, and that is lead to the phosphocreatine. In the past, the creatine kinase myoglobin hyper, the isoenzyme used as a diagnosis of a myocardial infarction, but nowadays they used troponin I and T, which they are the cardiac specific non-enzymatic markers. So in the old days, in the past, they just used the CKMP, that's mean creatine kinase myoglobin, because they are hyper, because it composed of a creatine kinase and myoglobin together. It used to diagnose the myocardial infarction, but nowadays they use troponin I and T, which they are non-enzymatic markers. Now I talk about the isoenzymes of the creatine kinase. There are multiple forms of the enzymes arising from the primary structure due to the genetically determined differences. So the multiple forms of the enzymes, they just arises from the primary structure due to the genetically determined differences. Yeah, because we learned what is the isoenzymes or isozymes. We said that is a multiple forms of the enzyme. So we have the creatine kinase, and we said that there are multiple isoenzymes for this. We just discussed before LDH, and we said that we have 5 LDH that is present in the different organs. So actually, because they just genetically differences, that's why they called isoenzymes. Isoenzymes can occur in a single organ or the cells. All the protein catalyzes the same reactions occur naturally in the single species. So all the protein, they just catalyzing the same reaction. And for example, the post-transitional modifications. Isoenzymes arises from the different gene loci, so they are just arises from the gene different loci, and we have also hypered isoenzymes. The hypered isoenzymes form when the subunits from the different loci combine. That's what we call them hypered. Hypered, that means we just make a connection between the two different things. So when we just have two different loci and just we form a subunit from two different loci, we called it as a hypered isoenzymes. And we have homopolymeric isoenzymes, which they are consist of identical subunits. But the question is, how can we just memorize this thing? It actually doesn't need to memorize these things, just we understand it. So we just start. Isoenzymes arise from the different gene loci. So we have gene, and the gene, it has multiple locus, and each loci can maybe form the isoenzymes. So when there is different loci and they just form maybe two different loci and just form one subunit, then we call it hypered isoenzymes. But if we just it forms subunit of the same loci, then we can say homopolymeric isoenzymes, because homo, that's mean they are similar to each other. Diamer composed of the 40 kilodalton subunits. It contains actually three different pairs of the subunits, which they are known as P and M. So we have PP, which is called creatine kinase 1. This is the first enzymes, which is composed of two things, which is two piomers or two diamers, which is known as P and P. So P, they are, we can say now it's homologous polymeric isoenzymes because they are just from the same identical subunit. So this is the creatine kinase 1. This is the isoenzyme 1. So, and we have P, which is called creatine kinase 2 because it contains from the different subunits, and that's what we call them as the hybrid isoenzymes. Again, it composed of 2MM, which is creatine kinase 3. This is homopolymeric isoenzyme. So now we understand these things. The numbers are based on electrophoretic mobility. So in the numbers that we are talking about here is depending on electrophoretic mobility. From the table, we notice that the heart, if relative to the CK activity, most abundant is CKMP, which is most abundant in the heart. Okay, and as I said before, that the CKMP, it was used as a diagnosis of the coronary heart diseases or any damage to the muscles of the heart. Not coronary heart disease, actually it's myocardial infarctions because it's due to the damage of the cardiac muscle, but nowadays they just use the troponin T and I. And in the case of the brain, we have CKPP. So remember PP, that's mean it referred to the brain. Okay, now we talk about the CK activity, that's mean the creatine activity. So we have the creatine phosphate plus ADP by the help of the CK. So we creatine plus ADP. I think it's the reaction absolutely wrong because the creatine plus ADP by the CKA plus ATP creatine like this, the arrow is like this. So the creatine plus ATP, that is lead to the phosphocreatine plus ADP by the help of the creatine kinase. And we have also another reaction like ATP plus glucose by the hexokinase. Hexokinase, that's mean we add a phosphate group to the glucose, so it will be turned to glucose 6-phosphate plus ADP, and by the enzymes is called glucose 6-phosphate dehydrogenase, that is lead to the 6-phosphogluconate. But we just focus that we change the NAD P positive to the NAD PH plus H positive, which is mean we can measure it by the photometry, which the absorbance equals 340 nanometers. The question is the CK affected by the hemolysis? You know what is happening in the hemolysis is a breakdown of the RBCs that is lead to an increase the bilirubin, that is an increase of the potassium level and many things. Okay, so the answer is yes and no. So why yes? Because the moderate hemolysis, that depends on the degree of the hemolysis. If it's moderate, hemolysis can be tolerated because the erythrocyte contains no CK activity. So like, you know, there is this damage to the erythrocytes, it contains no CK. So why this CK appears in the severe hemolysis can be affected because enzymes and the intermediates may affect the lag phase and the PROMET site reaction in the assay system. Okay, if you're just telling me that there is no CK in the erythrocytes, so why in the severe hemolysis it affected? Because in the severe hemolysis, it's severe hemolysis. That's mean maybe that is activate many enzymes and the intermediates, and that is affect the lag phase, and that is promote the destructions of these muscles, and that is lead to like a side reaction and it increases the CK. So if this questions is like, is the CK affected by the hemolysis? That depends on the degree of the hemolysis. Of moderate hemolysis, sure, no, because there is no CK in the erythrocyte. But in the case of the severe hemolysis, because the intermediates and the enzymes affect the lag phase, and that is will be an increase as a side reactions lead to an increase of the CK. Now we're talking about the hybrid isoenzymes, which is called CKMP activity. Diagnostic time window after the myocardial infarctions that is happen after 8 to the 24 hours. So should we diagnose it between this time window, which between 8 hours to the 24 hours? CKMB can be useful if the total CK is more than 100 unit per liter. So that's why we can say it's not a specific, because it affected with the total CK. If the CK total CK is more than 100 international unit, that's mean the CKMP it's useful now to be used. Total CK in myocardial infarction rarely more than 7,500 international unit. In the myocardial infarction, CKMB typically it's about 6 to the 25% of the total CK. That's why we said that if the total CK is more than 100 international units, so we can use the CKMP, because the CKMP it's about 6 to the 25%. Actually, the ratio of the CKMP from the total CK it's about 6 to the 25%. If the CK increase but the CKMP, so you notice that the CK is so large, and then you measure the CKMP and you found it's less than the 6%, then that's mean it's a skeletal muscle damage. It's not related to the heart. But if the CKMG it's more than a 25%, okay, then that suggests that is macro CK without CKB. That's mean if it's an increase more than subunits or CKBP, it's maybe that's due to these things. So just like focus why the CKMP more than a 25%, because there is a macro CK, I mean without CKP, like there is M without P, or there is CKPP, and that is the reason why it's a 25. But normally and typically the CKMP it's between 6 to the 25%. If it's less than the 6%, so it's related to the skeletal muscle damage. If it's more than 25%, then that's a macro CK or CKPP. Immunoinhibition test determine residual activity of the total CK following complete inhibition of the CKM activity with antibodies. Then multiply 2 and then the results. So I don't want to skip it as something is so easy, so that's why we called it immunoinhibition test. If you just remember, if you just like mention immuno, that's mean we use antibodies, so we are just deal with that. But why it's inhibition? Because it causes inhibition with the CKMP. But how we can inhibition it? By the antibodies. If you just forget completely what is the immunoinhibition test causes in the CK, just it determine the residual activity of the total CK. It doesn't focus on the CKMP or PP or whatever is it. It just determine what is the residual activity of the total CK by the inhibition of CKM by what? By the antibodies, and then we multiply it by 2. How to identify and measure the activity of the different CK isoenzymes? We just how to define that, like a CMP, or what we can use, separating CK isoenzymes based on the size and the charge using electrophoresis. So I think we use, because we know that the most of these isoenzymes or most of the enzymes are just proteins, so we use the protein electrophoresis. And actually we didn't use SDS because we want to know how they are just separating depending on the size and the charge. And I remember that I just told that before, that we use the I forget what its name, but it's not SDS, because it makes everything the same charge, the same maybe the same charge, not the size, because they are separating depending on the molecular size. And we said that the native the native protein electrophoresis that is used for the measures of the enzymes, because we want to separate them depending on the size and the charge. Performing the reactions on the gel, because it's a gel electrophoresis, we use stacking gels, we use separating gels, we use this stuff to generate of the NADH, which is a fluorescent, measuring the fluorescence to quantify each of the CK isoenzymes. How to measure the concentration of the CK, not the activity, by the immunoassay. So I use the immunoassay just to measure what is the concentrations of the CK, not the activity. I'm not talking about the activity. So the antibodies stick to the CKMP, then they created a signal which is color change light, then we measure the CKMP depending on the strength of the signals. That's why we called it immunoassays. Just we use antibodies, they just stick to the CKMP, then the color will change, and we can determine the concentration of it. CKMP is less sensitive and less cardiac specific than the troponin. As we said, we use troponin nowadays. We use troponin T and I for the diagnosis of the myocardial infarction, not CKMP. CKMP in the old days, that was used for the diagnosis of the cardiac myocardial infarction. Now we're talking about the cardiac troponin complex. They are just the contractile proteins of the myofibers. It includes 3 troponin regularity proteins. As you can see, they are contractile proteins, so they are just responsible of the contractions of this protein of the myofiber, and they just contain the 3 troponin regularity proteins. Various monoclonal antibodies based immunoassay exist for troponin I and the troponin T, so we use a more specific antibodies which they are called monoclonal antibodies. But the challenges, what are the problems here, that there is no primary reference for the troponin I. Material is currently available for the manufacturer to use in standardizing troponin I assay. The troponin I circulates in its various forms, and the different antibodies use the variable assay recognize different epitopes of the troponin I, even for the different assay and instruments marketed by the same manufacturer. High sensitivity cardiac troponin assay. They are just high sensitivity because the CV is 10%. I mean the coefficient of the variant 10% or less than 90% CT above the limits of the detection, and 5% reported as the values nanograms per liter, 6 specific cut-offs. That is for the troponin cardiac enzyme. And then we're talking about the factors that is affecting the 99 percentile. The first one is age, older age, high troponin levels. We should care about this, we just focus about this. That is older people, they are just contain a large amount of the troponin levels. So if it's an increase, if we just measure, we should consider the age, because it's maybe normally there is an increased level of a troponin level. And as you can see here, about the 6, that is the male more than the female in a troponin level. Different test, each test needs its own cut-off value, so it will be like each test has a value on the sample time, if it's serum or a plasma or the whole blood. The results are very depending whether it's a serum or a plasma or the whole blood, so there are many factors. The sensitivity of high sensitivity troponin assays allow for the measurement of the troponin in the normal healthy individual before just measure when there is necrosis or myocardial infarction. Sensitivity of high sensitivity troponin assays allow the measurement of a troponin in the normal health before it happens like a necrosis or myocardial infarction. And now we talk about the SCOT enzyme. As you can see here, we wanted to know what is happening to the SCOT enzyme. As you can see here, we have here free fatty acid that they are just present in the blood, and these free fatty acid that just go inside the liver, and then it happened free fatty acid oxidation. So the fatty acid oxidation that is lead to the acetyl coenzyme A, and the acetyl coenzyme A was also another acetyl coenzyme A, and we just describe that. It will be explained more in other resource by the enzyme is called 3-hydroxy 3-methyl glutaryl enzyme, or S2, that is lead to the formation of a 3-hydroxy by the help of leucine 3-hydroxy 3-methyl glutaryl, and then by the HMGCl that is lead to the acetoacetic enzyme acid, which not enzyme, acetoacetic, which is the first ketone body. Okay, and by the enzyme is called BDH. Okay, then that is lead to the 3-D3-hydroxy 3-butyric acid, which is the second ketone bodies. It will completely enter the brain, as you can see here, and it's reversible enzyme that is lead to the acetoacetic enzyme, and then a Scott enzyme, acetoacetyl coenzyme A, MAT acetyl coenzyme A, and then the citric acid cycle. So what we want just to focus, that is acetoacetate by the Scott enzyme that is will turn to the succinyl coenzyme A to the succinate, so that is lead to the acetoacetyl coenzyme A, and by the help of the MAT and coenzyme A, that is lead to the formation of acetyl coenzyme A, acetyl coenzyme A. Thiolase enzyme activated via spectrophotometric assay. We are talking about the Scott. Thiolytic cleavage of acetoacetyl coenzyme A is assessed as 303 nanometers. And now we talk about the rate reactions, which is measures the time chosen to reflect the target analyte. As you can see here, the sample, the active reagent is added, and reaction of the interfering substances, and then there is reaction of the target. And here we have the enol and the ketone. The enol, more complex with the magnesium, has an absorbance of 303 nanometers. Now we're talking about the other substance, which is called iodoacetamide, which is alkylating agents, inhibit free sulfhydryl groups of the proteins, prevent thiol groups oxidation or modification. Scott enzyme contains cysteine residuals, which is important for its function. Iodoacetamide irreversible bind to the thiol group, blocks potential interfering reaction or oxidation. Iodoacetamide stabilize the enzyme activity by preserving the structural integrity of the enzyme. And then we talk about the newborn screening for the metabolic diseases. As we can see here, tandem mass spectrometry, not proceed by separation, can be found in a newborn screening for the inborn errors of the metabolism. So blood must be applied in an even and sufficient manner onto filter people card, but the card must also not be overloaded. Prior to the shipment, drying at ambient temperature. In Germany, parental consent required. Then we're talking about the other disease, which is called phenylketonuria, which I discussed it in the separate video. The symptoms: impaired myelination, mental retardation, spasticity, hyperactivity, spasticity, hyperpigmentation, tendency to develop eczema, untreated, apparently normal for several months, subsequently several impairment of mental development. Excellent prognosis if the treatment with the phenylalanine restricted diet is started very early in the asymptomatic patient, even not that is lead to the appearance of all these symptoms. So we just save the patient, which is like fetus, I mean here. A very small change in the gene level, such as single base transition or point mutation in the PAH, phenylalanine hydroxylase gene coding for the phenylalanine hydroxylase can be amplified many 1000 times, which is the effect is measured on the metabolite level. So we have the phenylalanine domain, phenylalanine hydroxylase, so that is lead to the tyrosine and dopa and dopamine, and the tyrosine to the adrenaline, thyroxine, melanin, which is so important for all these conditions. So phenylalanine hydroxylase deficiency is the cause of the phenylketonuria, leading to the severe mental handicap if not treated early. That's what I am talking about. And then the Fooling test, FeCl3 solution on the diabetes, requires high phenol ketone levels to be done or to be manifested. And then the current list of the target disease in a newborn screening in Germany: phenylketonuria, hyperphenylalaninemia, congenital hyperthyroidism, adrenogenital syndrome, classic galactosemia, tyrosinemia type 1, maple syrup urine disease, isovaleric acidemia, glutaric aciduria type 1, deficiency of creatinine cycle fatty acid oxidation, biotinidase deficiency, cystic fibrosis, spinal muscle atrophy, severe compound immunodeficiency, and also skeletal cell disease. And by this we end the second part of the lecture 10. Hope you understand anything.